Hello again, students. This is my second lecture, and this is basically based on right-sided heart failure and left-sided heart failure. I decided to do the lecture on this topic separately because this is what you deal as nurses when it comes to cardiovascular system disorders. So let's go to the next slide. Now this is the picture of heart, and I think you might have heard it million times that the major purpose of the cardiovascular system is to provide oxygenated blood to our cells and return deoxygenated blood to the heart, where it travels to the lungs to be reoxygenated. First of all, you need to understand that deoxygenated blood comes from the body and it's coming from the venous system. So venous, venous system, and travels via the um, inferior uh, uh, inferior vena cava, which is coming from the lower body, and superior vena cava, which is coming from the upper body, to the right atrium. Now, blood flows from the right atrium to the right ventricle and out to the lungs through the pulmonary artery. And I received everybody's uh, diagram of blood flow through the heart, so I know we all are good on this topic, how the blood flows to the heart. And now, after going from right atrium to the right ventricle and out to the lungs through the pulmonary artery, the blood then picks up oxygen in the lungs and travels via the pulmonary vein to the left atrium and down to the left ventricle. So from the left ventricle, oxygenated blood is then pumped out through the aorta to the body. So this is the very basic information which you need to know before we even start discussing about any, abnormality. The entire heart is like a pump, and it is moving the blood in one direction, which is forward. If the blood is not moving forward, it backs up into the venous or arterial system. If the right side of the pump begins to fail, blood backs up into the venous system. And when the left side of the heart fails, what happens to the blood? Then the blood um, then blood backs up into the lungs, preventing blood from being pumped out to the rest of the body. So this is very important, very basic information or the concept which you need to understand. I will repeat. If the right side of the pump begins to fail, blood backs up into the venous system. When the left side of the heart fails, blood backs up into the lungs, preventing blood from being pumped out to the rest of the body. Now, forward flow of the blood, how the blood is flowing in a forward manner, and it is forward flow, blood flow is going out of the left ventricle. It can be measured through a special catheter which man has made, and it is called uh, thermodilution catheters, and they're popularly known as pulmonary artery or Swan-Ganz catheters. Swan-Ganz catheters, swan the bird, Swan-Ganz catheters. And they are used to measure the cardiac output or forward flow of blood in the form of tissue perfusion out of the left side of the heart. So the forward blood flow out of the left ventricle can be measured using a catheter called Swan-Ganz catheter, and this measures the cardiac output or forward flow of blood out of the left side of the heart. Now, if cardiac output drops for any reason, this means the left ventricle has decreased forward flow. So if cardiac output drops for any reason, this means that the left ventricle has decreased forward flow. If this decrease in forward flow is very major, the patient may show signs and symptoms of decreased cardiac output. The most important critical thinking um, or a most important USP of any nurse can be how competent she is in the assessment of the patient's cardiac output. And we do this all the time. Maybe you have done it all the time on the floor and you don't even realize that you are actually measuring, you're actually assessing patient's cardiac output. Uh, a quick way to do the cardiac output assessments includes first the level of consciousness, blood pressure, skin temperature, lung sounds, urine output, and also peripheral pulses. So these are the quick assessments which you can tell about the you can do about assessing cardiac output of patient. Now let's go to the next slide. The role of cardiac output. Now, cardiac output is the amount of blood ejected from the left ventricle over 1 minute, and usually it's said to be 4 to 8 liters per minute. Okay, so uh, if I have to test you, I might test you on the definition of cardiac output, and you should also know this very well, it's because it's amount of blood ejected from the left ventricle over 1 minute, and usually they say it's from 4 to 8 liters per minute. Why we are so much concerned about the cardiac output? Because cardiac output should remain fairly constant or adequate to maintain the uh, whole body perfusion. And uh, and if the patient has this the amount of blood ejected from the left ventricle over 1 minute, and if it is between 4 to 8 liters per minute, it means that the patient has adequate cardiac output. Now, now before I tell you what's the formula of cardiac output, let's go to the definition of stroke volume. It is amount of blood ejected with each heartbeat. So, stroke volume is amount of blood ejected with each heartbeat. Okay, so there is one heartbeat, boop, and then there is some blood which is coming out. That's called stroke volume. Now, cardiac output formula is, which you might have heard many times, is heart rate into stroke volume. Heart rate, I don't need to explain you, but stroke volume has three factors: preload, afterload, and contractility. Now, I have heard many times students saying, oh, it reduces the afterload, preload, but you need to be very clear in these concepts, because if you understand these concepts, it will also help you understanding how certain medications, heart medications, they play a role in managing these uh, terms: preloads, afterload, and contractility. No, I think I put the stroke volume definition uh, two time on the PowerPoint, so ignore the second definition. It's one and the same thing. Now, as I was saying, stroke volume is influenced by three factors, and which is preload, afterload, and contractility. Preload, the first one, preload is the amount of blood returning to the right side of the heart. To just make this clear, if you think of preload, think of volume. So you can have too much or you cannot have enough. And the ways to increase this preload is that we can increase fluid volume in the vascular space. So if we have to increase the preload, we can increase the fluid volume in the vascular space. I don't have to explain you the meaning of vascular space. By this time, you should know what is the meaning of vascular space. We can elevate the patient's legs or place the patient in the Trendelenburg position. Ways to lower the preload is to make the client sit up with the legs down and decrease vascular volume. Okay. So preload is the amount of blood returning to the right side of the heart, and to remember this, think about volume. And ways to increase preload or increase volume in the vascular space is to elevate the legs, elevate the patient's legs, and place the client in the Trendelenburg position. And ways to decrease preload is make the client sit up with the legs down and decrease the vascular volume. So preload is all about vascular volume. Let's go to afterload. The afterload. And the afterload is the pressure in the aorta. So and peripheral arteries that the left ventricles has to work against to get blood out. So the afterload is the pressure in the aorta and peripheral arteries that the left ventricle has to work against to get the blood out. So there is a pressure in the aorta and there is a pressure in the peripheral arteries, and the main you know the main what you can say, the main key worker, or key employee of the heart is left ventricle. He has to work against the pressure in aorta and peripheral arteries, so to get the blood out to the heart. This pressure is referred to as resistance. How much resistance the ventricle has to overcome to pump the blood out to the body. The You always remember the iota or aorta, whichever way you want to say. I mean, I say iota. The aorta is naturally a high pressure vessel, but we don't want it to get too high. We don't want too much pressure in aorta. It's bad. Ways to increase afterload include making the client's blood pressure go up. So now the client's left ventricle will have even more pressure to pump against. As a result, less blood will be pumped out of the heart and cardiac output will go down. So this is not good. So ways to decrease afterload are to give the patient something, a drug. It can be a vasodilator medicine or antihypertensive medicine. This will decrease the pressure in the aorta, and therefore the heart will not have as much pressure to pump against. And then the left ventricles will be relaxed, and so the important employee of the heart can say, I can relax, and I don't have to work as hard against the high pressure of aorta to get the blood out. And then the cardiac output will go up. It sounds a little complicated, but I can explain it again. When there is the pressure in the aorta and peripheral arteries that the left ventricle has to work against to get blood out, this is known as afterload. Afterload, no, no, afterload is the pressure in the aorta and peripheral arteries that the left ventricle has to work against to get blood out. Now, this pressure is referred to as resistance. And how much resistance the ventricle has to overcome to pump blood out to the body. The aorta is naturally a high pressure vessel, but we don't want it to go too high, and the ways to increase afterload include making the client's BP, the blood pressure, go up. Now the client's left ventricle will have even more pressure to pump against. As a result, less blood will be pumped out of the heart and cardiac output will go down, which we don't want. So we want to decrease that afterload. So ways to decrease afterload is to give clients some vasodilator or antihypertensive medicine. This will decrease the pressure in the aorta, and therefore the heart will not have as much pressure to pump against as before. then the left ventricle, the most important employee of the heart, will say, thank you, I don't have to work as hard as I was working earlier, and then the cardiac output will go up. This is what you need to know about afterload. The third one is contractility. uh, Contractility is very simple. How much heart is capable of squeezing the volume out of the ventricle. So how much heart is capable of squeezing the volume out of the ventricle. This is what you need to know about, you know, three factors of stroke volume: preload, afterload, and contractility. And uh, our goal is always to increase the cardiac output. When you hear the word cardiac output, you think about left ventricle. Okay. Now let's go to the next slide. Now there are body systems which contribute to the homeostasis when it comes to the cardiovascular system. And there is the first body system which you can see working closely with our cardiovascular system is central nervous system. And then in central nervous system, now there are some very sensitive nerve endings and baroreceptors which are located in the atria in the heart. And then there is carotid sinuses and aorta. All these three, they sense the drop in cardiac output. And anytime there is a decrease in our cardiac output, these structures will cause the activation of the sympathetic nervous system response, which is fight or flight. Then epinephrine or norepinephrine are secreted into the blood. Epinephrine increases heart contractility, thereby increasing cardiac output. Epinephrine and norepinephrine also act as potent vasoconstrictors, so the blood pressure goes up. And when the parasympathetic system, if it gets activated, it will basically will do the opposite of the sympathetic nervous system. Activation of the parasympathetic nervous system will lead to slowest heart rates and will cause vasodilation. That means it will make the blood vessels, you know, go bigger, dilate more. So uh, and will have a slow heart rate. So central nervous system plays roles in a way that when there is a decrease in cardiac output, it will activate the sympathetic nervous system. And uh, epinephrine and norepinephrine are secreted into the blood, and epinephrine increases heart contractility, thereby increasing cardiac output. So the squeezing power of the heart, the amount of blood can volume it can get out of the ventricle, it speeds up, and so the cardiac output increases. This is how central nervous system plays its role in maintaining homeostasis, you know, um, in maintaining homeostasis uh, in conjunction with cardiovascular system. Now there is two other systems. So, where the there is another system which plays a heavy role in maintaining or in contributing to homeostasis as regard to cardiovascular system, and the other one is endocrine. And we'll be discussing about the renin, angiotensin, aldosterone system, and then we will discuss about ADH, and then we'll discuss about BNP. Now let's talk about BNP. BNP, B as in baby, N as in Nancy, P as in protein, and you can memorize the full form. Now, BNP was first discovered in lesser amounts in brain, and it is a hormone secreted mainly by cardiac cells in the ventricles in response to wall distension, which is volume overload. Secretion of BNP will cause diuresis and vasodilation. So when there is BMP secretion, we'll call diuresis and vasodilation. Diuresis will decrease the volume in the heart, which is preload, and will decrease workload on the heart because there is less volume to pump. And the vasodilation decreases afterload, which is resistance, lessening the workload on the heart. When the BP, when this BNP is secreted, blood pressure will go down. And the BNP is measured as a lab value, and it is used to classify the degree of heart failure. Higher the BNP or higher the number, the worse is the heart failure. So that's why you need to know the importance of BNP. Then we talk about antidiuretic hormone. I don't know if you have done fluid electrolytes and how far you remember this ADH. It is housed in the pituitary gland in the brain. It is a hormone. The brain through osmoreceptors, which are located in the hypothalamus, can sense when the blood is concentrated or dilute. In response to increases in the concentration of blood, ADH is released and leads to water retention. Increases in water retention increases blood pressure. More volume, more pressure. So when the blood is concentrated or dilute, brain can sense it, and then the antidiuretic hormone comes in action. There is something, now we're going to renin, angiotensin, aldosterone system. Whenever there is a decrease in cardiac output, kidneys will sense it. Kidneys will sense this decrease in perfusion, and something called renin, R-E-N-I-N. So R is Robert, E as England, N as Nancy, I as India, and N as Nancy, and renin is secreted into the blood. Secretion of renin converts something called angiotensinogen, which is produced by the liver, into angiotensin 1. In the lungs, angiotensin 1 is converted into angiotensin 2 by a very famous enzyme which you have heard while doing your medication medication summary, by angiotensin converting enzyme, which is also known as ACE. So let me begin again. If there is a decrease in cardiac output, the kidneys sense this decrease in perfusion, and renin is secreted into the blood. Secretion of renin converts angiotensinogen, which is produced by the liver, into angiotensin 1. In the lungs, angiotensin 1 is converted into angiotensin 2 by ACE, which is angiotensin converting enzyme. Angiotensin 2 is a very major vasoconstrictor. In response to the circulating angiotensin, aldosterone is released from the adrenal cortex too. Aldosterone causes the retention of sodium and water. Activation of this system makes blood pressure go up. Whenever you see aldosterone, you should always think about sodium and water. When you have more volume, blood pressure goes up. ACE inhibitors stop the conversion of angiotensin 1 to angiotensin 2, thereby decreasing the blood pressure or the afterload. Also, lesser amounts of circulating angiotensin 2 decrease aldosterone levels, resulting in less retention of sodium and water. So now that's how your ACE inhibitors work in regard to the blood pressure. So this is what you need to know about the body systems contributing towards the uh, um, circulation of blood. Now let's go to the next slide. It's very quiet in my house, so it's very good to record this lecture right now. Okay, now let's go to the causes of left-sided heart failure. And as I have mentioned here, uh, now before even saying left-sided heart failure, I want to say there is a blanket term called congestive heart failure. Now, congestive heart failure is classified as left-side heart failure or right-sided heart failure. Now, let's go back to this slide. It says left-sided heart failure. Left-sided heart failure occurs when the left ventricle fails and cardiac output falls. So, left-sided heart failure means left ventricle has failed and cardiac output is getting down. The blood here backs up into the left atrium and lungs, causing pulmonary congestion. Now, causes of left-sided heart failure is first one is coronary artery disease. What does coronary artery disease do? It reduces oxygen-rich blood flow to the cardiac muscles, resulting in ischemia. I'm not going to define ischemia for you. You can look up in your medical dictionary. This decreases cardiac output. So CAD reduces oxygen-rich blood flow to the cardiac muscle, resulting in ischemia, and this decreases the cardiac output. As the damaged cells begin to um, as the damaged cells they begin to get healed, they go through some remodeling, and this remodeling is a very bad thing. The scarred or the remodeled tissue, the scarred or the remodeled tissue is not the same as the healthy heart tissue. The remodeled tissues or the remodeled cells do not contract as well as the healthy heart tissue, and the patient is at risk for developing congestive heart failure. So that's how coronary artery disease can lead to congestive heart failure. There is next one is MI, which is myocardial infarction. Infarction, that means there is a blockage of coronary artery which is impeding the forward blood flow, resulting in again in cardiac tissue ischemia. This reduces cardiac contraction and cardiac output. In MI, there is a blockage of coronary artery which impedes blood flow, impedes 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 blood flow, resulting in cardiac tissue ischemia, and this reduces cardiac contraction and cardiac output. See, again the cardiac output comes. Cardiac output is the hero in our life, so it should be maintained adequately. Now it's called myocarditis or endocarditis, and myocarditis or endocarditis, whatever it is, it is referring to the myocardium or endocardium layer of the heart. And what happens? Itis, so it is inflammation. It's inflammation of heart muscle which can be caused by bacterial, viral, or any other infection. This can damage heart muscle, and what will happen? By damaging heart muscle won't work effectively and it won't pump effectively. The second one is heart valve disorders. Heart valve disorders are when there is narrowing of heart valves and it's causing the backward flow of blood. Remember, if you look at the YouTube animations and all that, you'll see how the valves they open forward. They open the forward and then the blood passes forward. But if there is narrowing of heart valves, they will cause the backward flow of blood. The heart enlarges and cannot pump effectively. So again, this decreases cardiac output. Then we have something called arrhythmias. And I think I have the spelling wrong here, but never mind. The arrhythmias, the heart beats abnormally, leading to decreased pumping ability. Arrhythmias, there's a problem with the heart's electrical conducting system. Then there is something called pulmonary hypertension. Pulmonary hypertension, it damages blood vessels in the lungs, so making the heart work harder to pump blood into the arteries that supply the lungs. Now, and then there is something called pulmonary embolism, and it makes pumping blood into the pulmonary arteries difficult because of blockage. There's somewhere there is an emboli. Now, hyperthyroidism. Hypothyroidism, it's over stimulates the heart, making it pump too rapidly. It makes the heart, get too high and starts pumping too rapidly and not emptying completely with each heartbeat. And if the heart beats too fast, the ventricles do not have time to fill. So that's why this does. I also want to mention it's not only hyperthyroidism but also hypothyroidism can also lead to left-sided heart failure, and where there is low thyroid hormones which makes the cardiac muscle weak and decreasing its pumping ability. Anemia is a very common disorder, and it's reduction of oxygen the blood carries, so the heart must work harder to supply the same amount of oxygen to the tissues. The heart is now working harder to pump more oxygen around the body. um, so when you have patients with anemia, you need to tell them, it's not just low hemoglobin, it can have long-term effect on the heart. Kidney failure. Kidney failure, it strains the heart because the kidneys cannot remove the excess fluid from the bloodstream, and this leads to decreased cardiac output. So this is what you need. These are the major causes of left-sided heart failure. Now, once I had student, he said, what happens with MI? He says the heart dies. Heart doesn't die with MI. Your heart will still pump pretty well, but not that effectively. So in MI, the heart is still pumping, but not effectively. Uh, so also, whenever there is a decreased forward flow of blood, that means the blood is also going backward. So decreased forward flow of blood in the heart is equal to backward flow of the blood. Whenever you see backward flow, whenever you think there is a backward flow because of valve or any structural abnormality or some kind of other related disorder, then you think that this patient is going towards the heart failure. The most worst case or complication of left-sided heart failure is pulmonary edema. Okay, so just remember that that's the most worst case of so the main key point to remember, the main key time to remember is all about cardiac output. So when the left side of the heart fails, cardiac output decreases and blood is not effectively pumped out to the body, causing poor tissue diffusion. So this is responsible for the left-sided heart failure. Let's do the signs and symptoms. I'm going to the next slide. Signs and symptoms are crackles, dyspnea, nocturnal dyspnea, orthopnea, cool pale skin, non-productive cough, blood tinged frothy sputum, restlessness, tachycardia, S3 and S4. I don't need to explain crackles in detail. We just got over with respiratory. Its crackles indicates pulmonary congestion. So there is a lung congestion, that's why. And shortness of breath, which is dyspnea, it's excess fluid interfering with the lungs' ability to pick up oxygen. And non-productive cough, there is something called non-productive cough. and it is a natural response to get the fluid out of the lungs to improve gas exchange. So those are signs and symptoms. Um, why there is blood tinged frothy sputum? Because blood and fluid are accumulating in lungs. Sputum will be frothy pink due to the presence of blood. Restlessness, yes, restlessness will be there because of hypoxia. Tachycardia, the heart rate increases as a compensatory mechanism, which is in an effort to pick up and transport more oxygen to the cells. So that's why the heart rate goes up. Um, if you all have been, I mean, you're in fourth semester. Since first semester, you should be knowing this, that S1 and S2 are two normal heart sounds, isn't it? So normally when there are two heart sounds, which is S1, which indicates the closing of the mitral and tricuspid valves, and there is S2, which indicates closure of the aortic and pulmonic valves. Well, when the heart fails, there is an extra heart sound called S3, and gallop. It is described as um, kind of floppy sound caused by extra fluid in the ventricles. They say the S3 sounds of the heart, it sounds like Kentucky. Kentucky. I don't know. Now, so S3 is abnormal, and you'll find S3, extra heart sound. S4, so atrial contraction against the non-compliant ventricle, it causes another extra heart sound, S4, and they say S4 sounds like 10SC, 10SC. Now you can go on the internet and Google heart sounds and see how whether S3 sounds like Kentucky or the S4 sounds like Tennessee. Okay, so you can do your own research on that, whether it sounds like that or not. Yes, so let's go to the next slide. Labs diagnostics, yes, we will do EKG, electrocardiography, and it will show the how the heart is getting strained, or if there is heart enlargement, is there if there is any ischemia. We'll do chest x-ray. We want to look at the picture and we can see if there are any lung infiltrates, if there is again big heart, and as I said earlier, your BNP will be increased. We can also do echocardiogram, which will evaluate the pumping ability of the heart and the function of the valves. Let's go to the next slide. How we will treat this patient. So we don't want this patient um, we don't want this patient to let's go to the slide. I didn't explain the pulmonary artery monitoring, So when I begin this lesson, I said there will be a pulmonary artery monitoring where you can measure the cardiac output. Well, it will show the elevated pulmonary artery wedge pressure and left ventricular end diastolic pressure in left-sided heart failure. So just remember, if you do the PA monitoring, it will show elevated pulmonary artery wedge pressure. Okay, the goal, then go to the next slide again. The goal is the most important is to decrease the workload of the heart. You can also prescribe diuretics to decrease fluid volume throughout the body. We can give ACE inhibitors, which will dilate the blood vessels, decreasing workload of heart. Then we can also go for angiotensin 2 receptor blockers, and the drugs which are in the category of angiotensin 2 receptor blockers, they can also be used in place of ACE inhibitors. We can give beta blockers, which will slow the heart rate and it will prevent remodeling of the tissue. Vasodilators, which causes blood vessels to dilate. And then there can be some positive inotropic drugs which makes the heart muscle contract more forcefully. Then you have something called anticoagulants. I don't need to say why anticoagulants is used. And then you have opioids. I wanted to make opioids in separate bullet point, but as soon as I type opioids and I go to the next bullet, the opioids becomes epoids, something like that. So the spelling changes. So I just put opioids next to anticoagulants. Now, opioids, they relieve the anxiety and they decrease the workload on the heart, especially in pulmonary hypertension. You can give oxygen, yes, it will improve oxygenation, and then we can also do some lifestyle modifications. And the nursing teaching can play a very major role in this, and that could be exercise, weight loss, reduce sodium, alcohol, fat intake, smoking, cessation, stress reduction, and all these can be a lifestyle modification to improve for this patient, for improvement in this patient. Then you have something called coronary artery bypass surgery or angioplasty. And this is done for heart failure due to coronary artery disease. So we can have that also. You can also go for heart transplant when the other aggressive treatments have not been effective. So these are the simple treatments which we can do for uh, left-sided heart failure patient. There are some complications related to left-sided heart failure. Pulmonary edema is the worst kind, and there is also organ failure. So slowly the heart failure is leading to destruction of all the other organs, heart, brain, kidney, and left-sided heart failure can lead to MI too, or they can be related. Next, go to right-sided heart failure. Okay. Um, Okay, I think this is already 40 minutes. So let me stop here and I will record right side and heart wave failure in another video. Okay, so this is not in. I'll be recording another video on right sided heart failure. Okay, thank you.